Good evening, friends. Welcome back to my channel, Pediatric Classes. Today we will discuss about yet another important topic, that is anaphylaxis. So how to manage, what exactly are the symptoms and all those things. So this discussion will be based on the IAP guidelines which has come recently. So once I was going through the guidelines, initially I thought like why should all of you will be knowing about anaphylaxis. So is it really required about a video on it? But then I realized that there are certain terminologies, exact definitions, the diagnostic criteria and all they are used in the guidelines. They're really good, very good guidelines, freely downloadable from the net. These are the IAP guidelines on the management of anaphylaxis. So with this introduction, let me start sharing the screen. So if you're not a subscribe to my channel, please do subscribe and support the initiative. So these are the standard treatment guidelines of anaphylaxis. At the onset, I would like to thank the Central IEP President, Ramesh Kumar Sir, the President-elect, Dr. Upendra Sir, Piyush Gupta Sir, IIUP President, and Vinay Saxena Sir, our Honorary Secretary General, and all the lead authors, Dr. Neeraj Gupta, and the co-authors, Dr. Akash Bang, Dr. Nihar Ranjan Mishra, and all the team members who are actually involved in bringing out such a wonderful guidelines. So what exactly is the definition of anaphylaxis? So anaphylaxis is an acute clinical syndrome characterized by life-threatening generalized type 1 hypersensitivity reaction. See, please note here, this is a question which can be asked to the NEET aspirants also. What type of reaction is an anaphylaxis? It is a type 1 hypersensitivity reaction. This is caused by an exposure to a foreign substance. Once that exposure happens, what happens is there's a mast cell degranulation and release of chemical mediators. So this definition says this is a type 1 hypersensitivity reaction and there is a mast cell degranulation relating to the release of chemical mediators. Okay. So the diagnosis criteria. This as anaphylaxis is highly likely when any one of the following three criteria are fulfilled. So what is the first criteria? This is an acute onset. When we say acute onset, that means the onset is within minutes to hours. Okay, minutes to hours. With involvement of skin, mucosal tissue, or both. And along with at least one of the following. That means either a respiratory compromise or a circulatory compromise. So we have to be very clear here. That means if a child is coming to you with an involvement of skin or mucosal tissue, when we say involvement of skin or mucosal tissue, it includes all the generalized hives or urticaria or a pruritus, flushing, swollen lips, or tongue or uvula, etc. So that shows that there is an involvement of skin or mucosal tissue. Along with it, just with that, we cannot say anaphylaxis. Along with it, at least a respiratory compromise or a circulatory compromise should be there. So, respiratory compromise means either dyspnea, Wheeze associated bronchospasm, low PEFR, stridor, or a hypoxemia. And circulatory compromise includes low BP or associated symptoms of end organ dysfunction like hypotonia, collapse, syncope, incontinence, etc. So what exactly is low BP? Please note here the last line says for children it is defined as less than 70 plus age into 2. So it's a birth from the very small baby from birth to 1 month. It is any SBP less than 60 is taken as hypotension. Whereas bigger children it is less than 70 plus age into 2. If it is coming below that, it is taken as hypotension. And anything less than 90 for 11 years and above is also hypotension. So suppose that 10-year-old, I'll say, suppose one 5-year-old child is coming to you and that 5-year-old child, at least the BP is 70 plus 2 into 5, that is 10. So at least if this SBP is less than 80, that is hypotension. So make sure one learning point here is whenever a patient is coming with anaphylaxis, please never hesitate to auscultate the chest. Look for bronchospasm or any wheeze and other things, and always do check a blood pressure because they can be associated with other circulatory compromise and all. So we need to manage it accordingly. So this is the first diagnostic criteria. Or they say there's a second criteria which is two or more of the following after acutely that occur acutely after exposure to a likely allergen for that patient. That means an involvement of skin or mucosal tissue with or respiratory compromise, or circulatory compromise, or GI symptoms. Any two. Okay. Any two means when we say GI symptoms, it is a crampy abdominal pain or vomiting. So this is another criteria. Third criteria is acutely after exposure to non-allergen for that patient, there is a reduced BP, which is defined as low SBP for the age, which we discussed less now, or more than 30% decrease in the systolic BP of that patient. So these are the three diagnostic criteria. So one is acute onset with involvement of GI or mucosal in tissue with one, either a respiratory system involvement or a circulatory system involvement. Or when we say it is two or more of the following, which includes involvement of GIT, RS, CVS, or the skin or mucosal tissue involvement. So two should be there. Or any patient, if it's coming after an exposure to non-allergen, the patient is having hypotension, please consider it as a case of anaphylaxis. So this is what we discussed just now. So what are the precipitating factors? Either an anti-allergic patient is taken orally, what? Drugs like antibiotics, NSAIDs, aspirin, for some food items like prawns, peanuts, or it can be different for different people. So that is another thing. Parenteral administration of drugs like antibiotics, paralytic agents, opioids, propofol, or insect bites and stings. Contrast media, contrast media, if you are giving to a patient for taking any contrast involved things, vaccines, blood products, etc. Physical contact with certain things like latex, others exercise. In case of food-dependent exercise-induced anaphylaxis also, it can happen. Okay. So what are the lab parameters? There is no much lab parameters which is requires a clinical diagnosis. But serial measurements of serum tryptase, another neat entrance question is here. Serum tryptase done at the acute stage and later can help to rule out systemic mastocytosis or pseudo-anaphylaxis. So what is a close differential diagnosis for anaphylaxis is will be a vasovagal attack. Patient has had a contact with something, or you can see just the patient fainted. So whatever it is, these are the differential points between them. In anaphylaxis, onset is within minutes, whereas vasovagal is in seconds. Okay, I told you anaphylaxis can happen with minutes to hours, whereas this vasovagal happens within seconds. Common triggers for anaphylaxis are medications, insect bite, exercise, milk, shellfish, etc. Whereas vasovagal is pregnancy, dehydration, extreme pain, fear, stress, heart blocks, etc. What about in anaphylaxis, what happens to the skin? The skin will be red, hot, peels, itchy, rashes, all will be there. Whereas in vasovagal, child will be pale and the skin will feel very cold. Respiratory system, you will see adventitious sounds like wheeze or stridor, whereas in vasovagal attack, there is nothing like that. The heart sounds will be, the respiratory breath sounds will be normal. In cardiovascular system, there will be tachycardia in anaphylaxis and there is can be associated hypotension. Whereas in vasovagal, when we palpate, there will be a bradycardia and there will be hypotension. GIT, nausea, vomiting can be associated in case of anaphylaxis, whereas vasovagal, they are non-specific. What happens when we give a prone position to anaphylaxis patient, there is no much improvement, whereas a vasovagal patient, there is a very good response with prone positioning. Treatment for anaphylaxis is injection adrenaline, whereas in vasovagal, we need to treat the cause. So let's now discuss the management algorithm. So if we actually see the guidelines, they are given in one single page. So I request the viewers to get that thing from downloaded from the net, and you can all have it pasted in your ER, that is emergency room, so that it becomes easier and a ready reckoner. So, what are we suspect? The clinical suspect is patient satisfying any of the three criteria which was mentioned earlier in the presence of a known trigger or precipitating factors. The first thing, even before this, the first thing is stop the trigger. Suppose we are an IV antibiotics is going, the patient develops a reaction. Immediately, first thing is stop the IV antibiotic given, or if it is on flow, just stop it. So like that. So what is one thing? Then keep supine positioning. If the patient is having respiratory distress or nausea vomiting, you can go for a sitting position also. Assess the airway, breathing, circulation, heart rate, BP, SpO2. Provide O2 at 10 to 50 liter per minute by NRBM if there is a respiratory distress or shock. Not a rebreathing mask. Okay. Identify and remove the allergic trigger if possible. Like for example, an insect stick. The main treatment is the IM epinephrine or adrenaline at the dosage of 0.01 mg per kg per dose. Please note here we are using undiluted epinephrine. Epinephrine is available as 1 in 1000, 1 milligram per 1 ml. So this should be given at the androlateral aspect of thigh. So the best thing to remember, so what I always used to remember is like for a 30 kg child, it is 0.3. Okay, 30 into 0.01, that is 0.3. So we will not forget. Otherwise, in that hurry things, there's a chance that we may think it is 0.1 mg per kg or 0.01, and you get confused. So please don't get confused. It is 0.01 mg per kg of 1 in 1000. So approximately for a 30 kg child, we can say it is 0.3 milligram epinephrine. Just take it, load it, and give it onto the androlateral aspect of thigh without wasting time. This can be repeated at 5 to 10 minutes interval as needed. So what happens from 1 to 5 minutes? If there's a respiratory distress, a sitting question can be followed and high flow O2 by HFNC and plan for intubation. If stridor is there, give the first nebulized epinephrine at the dosage of 0.5 ml per kg. If wheeze is there, first nebulized epinephrine should go at 0.15 mg per kg. So I can tell you one easy way to remember this salbutamol. Generally, we take 0.5 ml and add 2.5 ml normal saline and all if you're taking a respiratory solution. So 0.5 mg per kg is same. If you're using the respiratory solution, it is same as 0.03 ml per kg of that respiratory solution. Okay. So whichever way you are easy to remember, you remember that. Hypotension, if or a poor perfusion or a loss of consciousness is there, go for supine positioning, access an IV thing, and just give the first bolus of normal saline at 20 ml per kg by IV or intraosseous rapid push technique. Well, what should we do from 5 to 10 minutes? If there's no improvement, give the second dose of epinephrine. Again, the same dosage, that is 0.01 mg per kg of 1 in 1000. If not done ALF, kindly access the IV or IO access and prepare for difficult intubation. For respiratory distress, second nebulized epinephrine at 0.5 ml per kg. There's the same dose for stridor. And if second nebulized salbutamol can be given at 0.15 mg per kg if there is a wheeze. Hypotension or poor perfusion or LOC, again the second bolus of normal saline at 20 ml per kg by intravenous or intraosseous rapid push technique, and prepare for IV epinephrine and alert the pediatric ICU or tertiary care center by that time. In 10 to 20 minutes, if there's no improvement, give the second dose of third dose of IM epinephrine, and if there's a respiratory distress, go for the third nebulized epinephrine if there is a stridor, or a third nebulized salbutamol if there is wheeze. Proceed for intubation. Hypotension, poor perfusion, LOC, start giving IV epinephrine at 0.05 microgram per kg per minute with titrating the dose by 0.02 microgram per kg per minute up to the effect. And the patient should be transferred to a pediatric ICU or a tertiary care center. If still no improvement, please suspect refractory anaphylaxis. In case of refractory anaphylaxis, start IV norepinephrine infusion. That is a persistent hypotension for 0.05 mics per kg per minute with titrating the dose by 0.02 mics per kg per minute up to the maximum of 2 mics per kg per minute. Or you can also consider IV glucagon bolus if they're for persistent anaphylaxis, or the patients are there on beta blockers at 20 to 30 mics per kg per dose, maximum 1 milligram. Okay, over 5 minutes followed by 5 to 10 mics per kg, mics per minute treated till the achievement of clinical effects. Again, we can to manage the case according to the pediatric ICU protocols. So how can you monitor and follow up these patients? So there's something called delayed anaphylaxis. This may be due to biphasic reaction. That means this happens in around 1 to 20% of cases and happens within 1 to 72 hours, mostly within 10 hours. After an initial improvement, again the patient will come back with stridor or hives and all those things. So there's called delayed anaphylaxis, or there is a protracted variety, which is a severe persistent anaphylaxis symptoms for 24 to 36 hours despite aggressive management. So these terminologies are like really important. Delayed anaphylaxis, which is due to biphasic reaction, or we can consider another terminology is a protracted variety, where it is a severe form persisting for 24 to 36 hours despite aggressive management. And we need to monitor the BP, SpO2, respiratory rate, the heart rate, beep, and other things. This should be done over minutes during the first 30 minutes, and then hourly for the next 24 hours, and then 2 hourly for the next 48 hours. Follow-up with the patient should be done at least 4 hours after last IM epinephrine injection. And in severe hospitalized cases, we need to do the follow-up at least for 3 days. So what are the indications for hospitalization? Do we need to admit all cases? Not required. But if these things are there, that means tachycardia, hypotension, in the sense SBP is less than 70 plus age into 2, or there is a stridor, V's or tachypnea. When we say tachypnea, that means the respiratory rate in 1 to 5 years is more than 40 per minute. If there's more than 5 years, it is more than 30 per minute. Of the more than 10-year-old child, if it is more than 20 per minute. So if it is like that, there's a fast breathing or a tachypnea, then the SpO2 is less than 95% in room air, or there's a history of severe protracted anaphylaxis, or there's a patient is having also comorbidities like asthma, arrhythmia, systemic mastocytosis, etc., or the patient is living in remote area, or a person still coming, they are presenting to our ER in late in the evening. So such things are there. Please consider a hospitalization. So what about this home action plan? So, certain people are more prone for allergy or anaphylaxis. So, high-speed itching is the earliest, most common sign, though it may not happen in a few cases. So, we can actually, such patient can have an EpiPen, which is green color is having a dose of 0.15 mg per kg, and yellow color 0.3 mg per kg. So, this is ideal. But due to limited resources in India, home-prepared IM epinephrine. That means 0.01 mg per kg of 1 in 1000 dilution in a 1 ml syringe over the anterolateral aspect of thigh may be a practical option. Can be kept for 3 months at room temperature with protection from light. Expiry date should be actually written for future references. So this EpiPen is actually a life-saving drug. So if anyone is having a recurrent episodes of this anaphylaxis, they should try to procure the EpiPen and have it at home, or go for a home prepared IM epinephrine injections. But the preferred one is always having a EpiPen at home. And if symptoms, a person never ever hesitate to contact the hospital to, once you get the epinephrine, it's always better you contact the nearest hospital and have the checkup out there. So in this session, this is in short, these are the learning points. This is a sudden severe life-threatening allergic reaction to an allergen with multi-system involvement. Early identification and management are the cornerstone of good outcome. We have discussed here the diagnostic criteria, which are IM epinephrine is a drug of choice. Follow-up of the patient. If it's a severe case, you have to follow up at least for 3 days due to biphasic nature of the anaphylaxis, education of the parent, and about its early recognition and appropriate management. We should try to avoid the triggers as far as possible too. This is the need of the hour. Okay, we have to tell the parents, educate the parents on his early recognition and also the appropriate management. We also learned about certain terminologies like protracted anaphylaxis and all those things that are also very important. So hope you like this session. And if you like this session, please don't hesitate to like it and share it with your friends too. Thank you so much and stay safe.